Hi, everyone. My name is Wendy Ott, and welcome to our Mental Health Crisis Interventions webinar today. We have with us our presenter, Melody Colmetz, and I'll talk a little bit more about her and her qualifications, but she is an amazing presenter. We're very happy to have her here with us. Because it's Mental Health Awareness Month, we thought this would be a great topic to talk about how everyone is managing the mental health crisis interventions as first responders. And as part of participating in this webinar today, you are able to earn CAPC accredited CEs. So the way that will happen is you will get an email following this webinar. So as long as you attend the webinar, you get the email and then you complete an assessment. And that email will have the assessment in it, as well as information on how to access your certificate. And as I said before, that will all come because you've attended the webinar to you in the email that you registered for the webinar with. So you should look for it there within 24 hours following the end of the webinar. So I just wanted to talk a little bit about Melody. We have an expert with us today, and she has a lot of great experience right now. She's a New York State certified paramedic and certified instructor coordinator. She has 30 years of experience in various types of EMS delivery services. She's a nationally certified physician assistant, 25 years of experience in primary care, emergency medicine, urgent care, gastroenterology, occupational medicine, and school physician services. She's also the director of didactic education at Ithaca College, and she provides clinical care as part of the Rochester Regional Health Mobile Surgical Services team at Northern Star Medical. This is on top of the background of education that she's put together, which you can see here. She has graduated from the Rochester Institute of Technology PA program, has a master's degree in physician assistant studies with a concentration in PA education from the University of Nebraska, and is also a Doctor of Philosophy candidate in curriculum instruction and science of learning at the University at Buffalo. And last but not least, an AMT regional faculty member and as a physician assistant foundation mental health outreach fellow. So you can tell she has a lot of great experience and training on how to teach, but also specifically how to teach this subject of mental health outreach. So I will not take any more time because I'm not qualified to talk about it and turn it over to Melody.
Well, thank you so much for inviting me today to talk about this topic that is near and dear to my heart. So I'll say, to summarize that introduction, two things. I really am a lifelong learner. I like to continue to stretch my brain, and I think that will fit in with some of the things that we're talking about today. And the second piece is I've had the opportunity in my career in EMS and as a PA to do a variety of different things. So I think that makes me uniquely situated to talk about kind of mental health and how things intersect as a pre-hospital care provider and as a PA in the inpatient and in the outpatient setting. So this particular topic has always been near and dear to my heart. I'm really interested in how people learn and how the brain works. That's one of the things that I'm looking at in my doctoral program. But mental health became a specific focus for me once I had the opportunity to become a mental health outreach fellow through the Physician Assistant Foundation. So I was fortunate enough to take mental health first aid training, and that started me on a pretty, I think, significant journey that has helped me share this message with other people, but it has also helped me as a clinician and as a healthcare provider to do a better job taking care of my patients, my colleagues, and most importantly, myself. So let's get started. A few kind of learning outcomes. I really, as an educator, spend some time thinking about what I really want you to get out of these programs. And you see these learning outcomes all the time. You're like, oh boy, more learning outcomes. But that's actually how I design what I'm going to present. I think about what are the messages that I want you as the learners to take out of my presentation. So we're going to talk about how diversity, equity, and inclusion really intersect with behavioral health, because number one, those are important topics that are getting a lot of attention in our world right now, rightly so. And I think we deserve to analyze how they impact or influence mental health or behavioral health. One of the things that I find helpful when I'm caring for patients is thinking about, is this a mental health crisis or is this truly a mental health emergency? So I'd like to give you some of those same tools to really assess the patient and the situation and potentially align that assessment with what opportunities there are for care. Hopefully, we'll be reminded or refreshed on some of the attitudes and skills that we need to safely and effectively work with folks who are experiencing mental health crises and mental health emergencies. We'll learn and touch on some patient assessment techniques, specifically types of communication techniques, which leads us to some de-escalation techniques. We'll be reminded of verbal and nonverbal cues that we should be paying attention to, and then some strategies that we need to think about. All right, this is a big problem. In the year 2019, 20.6% of US adults experienced some form of mental illness. That's 51.5 million people. And I'll remind you, 2019 is pre-pandemic. That just happens to be the most current data that I could pull. That's 1 in 5 adults. And when we think about, as we move through the presentation, sort of common mental health crises and more serious or urgent ones, 5.2% of people had serious mental illness. That's 13.1 million people. That's 1 in 20 adults. So when you think about the number of folks that you interact with on a regular basis, at home, at work, out in the community, look around and think about those numbers. 1 in 5 adults with a mental illness and 1 in 20 with serious mental illness. We could talk about youth and pediatric mental health. You know, that's another whole separate topic that is also near and dear to my heart. And I think we're going to see a lot of interesting data come out of the pandemic and our educational system. So stay tuned for that. I think in the US, sometimes we have a tendency to be sort of egocentric. We think about the US as a whole. But one thing that I learned since participating in a medical mission trip a couple of years ago is it is amazing to me that the problems that we experience are the exact same problems that other countries experience. So I've really tried to look at things from a more global perspective. I've added the World Health Organization to one of my lists of sort of trusted sources where I go to for information, because I really want to know not just what's affecting us in the US, but what is affecting other countries. So globally, 1 in 7 people have 1 or more mental health or substance use disorders. So that's a pretty significant number, and it's in pretty much alignment with what we're seeing in the US. We have to think about, we've got numbers, but do those numbers translate to specific ages and stages and populations, and who really has more weight to deal with mental health disorders? So a little bit higher population percentage female as opposed to male. The ages are kind of interesting. 29.4% are ages 18 to 25. 25% in my age range there, 26 to 49, although sadly I won't be in that age range too much longer. And then 14% 50 and older. So it does affect our older folks as well. Sometimes people think that mental health disorders are really a disorder of young people, but that's not necessarily true. And when we look at race and ethnicity, it's kind of all over the place as well. And I agree that this is a touchy subject. And some places are saying, why are we even collecting this data? Why do we even have to put that information on questionnaires and on forms? But I think at least looking at those numbers helps us tune in to some of the unique needs of those populations. And that leads us to the next discussion. Cultural concerns. Each culture has a very significantly different way of looking at mental health. Some are very open And some have a significant amount of stigma that can really limit the ability for people who are struggling. It makes it very difficult for them to speak openly and to ask for help. There can be some issues with understanding mental and behavioral health symptoms as well, because sometimes some of those symptoms are accepted as normal in that specific culture and aren't really recognized as a medical concern. Cultural factors can figure in when we're looking at community support as well. Some cultures are very supportive, some cultures are less supportive. So we need to be thinking about that, who the support person is, and are they local, are they far away, are they going to help us facilitate treatment for our patient? And then resources. It can be difficult and time consuming to find resources and treatment options that look at patient-specific cultural factors and cultural needs. So just some things to be mindful of when we are working with our patients. And that leads us to a discussion about diversity, equity, and inclusion. And again, I waffled about including this stuff in the webinar, but I really feel like it's important and it helps us look at mental health concerns with a little bit of a different lens. So we have to have some definitions in order to do that. So the first definition is diversity. It really is any dimension or any sort of criteria that can be used to differentiate groups and people from one another. So almost categories, if you will. But when we categorize, we need to have respect for and appreciation of the differences between those categories. And that's important when we're caring for all of our patients, whether they have behavioral health concerns or not. Every individual brings diverse perspectives, work experience, lifestyles, cultural experiences, etc. So we can't compartmentalize every patient into the same compartment, into the same space. And on that same token, some folks have more positive experiences, some folks have more negative experiences, and those experiences affect equity. Equity is freedom from bias or favoritism. And when we talk about bias, you'll see that some cultures and some populations do experience favoritism and others experience discrimination as a result of bias. Equality is another important term. It's a goal to ensure that every individual has an equal opportunity to make the most of their lives and of their talents. That's one of the things that I really try to focus on with my learners and with my patients. No one should really have poorer chances in life because of where they were born, where they came from, what their beliefs are, whether they have a disability. It's really important that everybody have an equal chance. And that leads us to a discussion about justice. So it's a concept. What's right based on ethics, law, natural law, religion, equity, and fairness. And it's not just about the law, but it's about administration of the law. So just be mindful of some of these concepts. We want to make sure that people have equal protection and they are not victims of discrimination on the basis of all of these different categories and even other categories. But the specific ones that are protected are race, gender, sexual orientation, gender identity, national origin, color, ethnicity, religion, disability, age, socioeconomic status, and there's other characteristics as well. So we want to be inclusive. Inclusion is a state of being valued, respected, and supported. I want every single person that I interact with, whether they are a patient, whether they are a learner, or whether they're even someone who's sitting in this webinar today, to feel valued, respected, and supported. And that's like my mantra. That's my goal every day. So now that we did all those definitions, you're saying, how the heck does that intersect with mental health? This is one of my favorite pictures. It hangs on the wall in my office because it reminds me of those things that we just talked about that I need to be thinking about on a regular basis, particularly when I'm interacting with my students. I want to make sure that all my students have the same experience I want to make sure that all my patients have the same sort of quality experience, but I can't, if you look at the equality picture, I can't give them the same experience if it's a boilerplate experience. I need to look at what are their needs. Maybe I have a patient that needs 2 steps on the step stool instead of 1. So just a kind of friendly reminder of how we should be thinking when we're interacting with folks. And the answer to that big question is bias. That's where things interact. Bias is a tendency or inclination or prejudice toward or against something or someone. And bias is often based on stereotypes. And I want you to really think about stereotypes for folks with behavioral health concerns. And I suspect we would all agree that there's an awful lot of stereotypes that lead to an awful lot of bias. And that bias can be harmful. It can cause patients to not get the care that they deserve. It can cause even more further reaching negative consequences than that. And the hard part is people might or might not even be aware that they hold those types of bias. So we're going to talk real quick about a couple of those types of bias. You may have heard some of these terms before. They may be brand new to you, but again, hopefully they'll give you a little bit of a different lens when you're taking care of patients. So anchoring bias, I can think of a whole bunch of EMS situations where I kind of have had to fight anchoring bias. Common situation. You see that 55-year-old male patient that presents with chest pain. Well, we think, oh goodness, he's diaphoretic and he looks pale. That must be a myocardial infarction. I'm focusing on one particular sign or symptom, and even the amalgamation of those signs or symptoms. And in my mind, oh, that must be an MI, and I have to treat it as such. And I forget that that's not really the only cause of chest pain. I can't ignore the other possibilities in my differential diagnosis. So is it a pulmonary embolism? Is it shingles because they have a rash on their chest? So avoiding anchoring is really kind of keeping an open mind and forcing ourselves to make a differential diagnosis for each and every patient that we take care of. Premature closure, I can use that same sort of example. You accept the initial diagnosis and you don't even look for any further information to challenge it. So we'll flip it and we'll say, okay, it's a 23-year-old pregnant female patient complaining of chest pain. So we say, it's a young female, can't possibly have a cardiac cause of that chest pain. So we're not going to look for any additional information because we've already ruled out cardiac. We don't search for any information. We don't do a 12-lead EKG, and we miss the opportunity to pick up the fact that this is a spontaneous coronary artery dissection, and that patient suffers as a result. Search satisfaction is another form of bias. We sometimes hear that when you hear hoofbeats, think of horses, not zebras, and that's helpful. But sometimes patients have more than one contributing problem. So if we find one thing wrong, we stop looking for more and give up and don't move along any further. And sometimes that comes back to bite us. And that leads us to another form of bias, is that zebra retreat. It's been pounded through our heads that common things are common. So if we see the potential for an uncommon diagnosis, we say, oh, can't possibly be that. I can think of one clinical case where a person presented with altered mental status. And I was fortunate enough to have some time to do a really good medication reconciliation. The person had all of their pills laid out on their nightstand by the side of their bed. And I could see that they were on one selective serotonin reuptake inhibitor, Zoloft, I think it was. And it was very clear that they were transitioning from one to another and that they were adding some additional behavioral health medications. Well, lo and behold, altered mental status can be a sign or symptom of serotonin syndrome. So I watched the patient carefully, got him to the hospital, obviously shared my information with the folks at the hospital, and they kind of shook their heads and said, can't be serotonin syndrome. So I asked for follow-up, and sure enough, it was serotonin syndrome because they were adjusting this particular patient's medication. So it is a relatively rare diagnosis, and even the hospital providers kind of had hesitation to look at that sort of zebra diagnosis. The bandwagon effect. We see that when we see the same types of patients all the way through one shift, right? So you see your first MI, and then the next person has chest pain. Well, that must be an MI too. Easy to kind of fall down that trap, especially when we're working long hours and long shifts. That's something we have to watch out for. And attribution error, so stereotyping, looking at the basis of the patient or their character rather than seeking a valid medical explanation. So if you see that patient who has disheveled clothing and is unclean and unkempt, automatically jumping to the conclusion that that person might be experiencing a behavioral health problem, that's a form of bias. We attribute their look to that mental health disorder, and that's not a fair process either, if you will. All right, so time for a little poll here. I'm going to ask you to take a minute to reflect on a time when you have been a victim of bias. And I ask you to take a moment to reflect on a time when you have perpetrated bias. So if you can go ahead and open up our poll, that would be great. So the first one, I've exhibited bias towards individuals, patients, family members, or friends with mental health disorders. And no kidding, no judging here. I'm asking you to be honest. All right. That's a pretty high percentage, maybe more than I might have even expected. All right, and how about the next one? I have been a victim of bias in healthcare. I've specifically talked about this from the lens of a healthcare provider, but we all have the potential to be patients too. So have you been a victim of bias in healthcare? Yeah, sadly, more true than false, which I kind of expected as much, but that still makes me sad. I can think of a time when it happened to me. Just real quick, short story. You saw I do some work in school health services. So about 10 years ago, I was doing a whole bunch of school sports physicals before the fall sports season started. So it was a really busy couple of days getting a school up to speed and really evaluating all the kids, making sure they didn't have cardiac issues and they didn't have any orthopedic issues and whatnot going on before the season started. And a couple days later, I started with a super high fever, like 104, and I felt terrible. But of course, I said, oh, it's probably just a virus, wait and see. A colleague of mine stopped over to drop something off at my house, and my colleague said to me, Melody, what is wrong with you? Your eyes are yellow. I was like, no, you're full of baloney. And he was like, no, go look in the mirror. Your eyes are yellow. And of course, once I noticed it, I freaked out and thought, oh my gosh, I'm jaundiced. This is crazy. So I went to the doctor the next day and immediately was asked a bajillion questions about my substance abuse history and how long I had been abusing alcohol because I was jaundiced. So you can kind of see where that bias came along. I was less than pleased with that particular healthcare provider because they automatically jumped to the conclusion, wow, she must be an alcoholic because she's jaundiced. Well, in the grand scheme of things, no, I'm not an alcoholic, and the cause of my jaundice was mono. I had contracted Epstein-Barr virus from the kids that I was working with in this school, and Epstein-Barr virus can cause a viral hepatitis. So I have pretty significant viral hepatitis as a result of that virus. So it's a good example of not being biased, if you will. All right, ready to move on to mental health crises versus mental health emergencies. So let's define them. What actually is a mental health crisis? It's a non-life-threatening situation, but the person is still having some extreme emotional disturbance or behavioral distress. It could be they're thinking about harming themselves or harming others. It could be they're disoriented. They do have that sort of altered mental status, or they're simply not able to function and care for their activities of daily living. So that's really a definition of crisis. And examples, talking about suicide threats. We hear that frequently now. Someone expresses threats of suicide on social media. So whoever sees it calls and asks for an evaluation. Talking about threatening behavior. Self-injury is a good one. Cutting is a common form of self-injury, and it often gets lumped into mental health emergency. But I'm here to tell you mental health crises. This is definitely a crisis. It needs attention, but we oftentimes focus on that behavior, the cutting behavior, which actually is the pressure relief valve for those patients. There's some reason why they're exhibiting that self-injurious behavior, so we shouldn't really focus on the behavior. We should really focus on what the backstory is, what's causing it in the first place. And then other examples, as I alluded to in my last example there, alcohol or substance abuse. Note that I did not say alcohol or substance use, it's abuse. And that abuse kind of target is difficult to define. Eating disorders can also fall into mental health crises. Not taking prescribed medications, that's common. People feel well and they think, I don't need to take that medicine anymore, so I'm going to stop taking it. But that can trigger a mental health crisis. Or just being distraught, depressed, angry, anxious. I'm seeing a lot more of that during the pandemic, and I suspect I'm not the only one that is seeing that. That's a crisis. That deserves attention. However, does that automatically deserve a trip to the locked psychiatric ward? I would say no. These mental health crises are the ones where it's appropriate to say, can we contact the mental health crisis intervention team? Can we contact your psychiatrist or your primary care physician? Can we get you a same-day appointment? When we move on to mental health emergencies, that's really a life-threatening situation. That person is in imminent danger of harming themselves or harming someone else. Or they just have such an inability to function. They can't get out of bed, they're not eating, they're not, again, not taking care of those basic activities of daily living, or they're just so distraught or out of control that it truly is an emergency. Those folks need immediate evaluation. So if you're acting on a suicide threat, not just threatening, but acting on it, you've got a plan in place and you have the items you need in order to see that plan to fruition. Same thing with homicide. You have a plan. You're threatening to hurt someone and you have a plan in how you're going to do it. Now, self-injury, as I talked about before, can go too far. That cutting can go too far, too deep, too much bleeding. That certainly deserves immediate medical attention. You're severely impaired by drugs or alcohol, or your behavior is just so unpredictable that you aren't able to care for yourself. That's truly an emergency. And like I say, those folks deserve immediate attention. We're seeing more in my area anyway, more alternative care pathways for folks that are experiencing mental health crises. And I've had to really kind of develop this thought process for myself. Is this really a crisis? Is this really an emergency? And I found that using that terminology has been helpful when interacting with law enforcement and with social work and the other care providers that are involved in the behavioral health team. So I hope that's a helpful kind of perspective or thought process that you too can use. And just remember, the difference is timing. There's risk of both, but when is it going to happen? and what is the threat level? How great a threat is this particular person? However, am I using this this difference between crisis and emergency to say, well, these people don't deserve attention? No, they deserve evaluation in a timely manner. We should never leave anyone alone or dismiss their concerns. I'm simply thinking about whether there could be other alternative ways of interacting with these folks where they end up with a better result. I don't know if anyone else has had the lovely opportunity of transporting someone to the psychiatric emergency department where they're evaluated, they're found not to be a risk, and then they're discharged back out on the street. I go back to the hospital with my next patient and I see them walking out the door. Do I feel like that person really got what they needed? Maybe not. So maybe they need to be seen by someone else that can really help them with their long-term problems. We've determined that there's not a short-term emergency, but we still have issues that need to be taken care of. So let's think about this one. Does bias intersect with our ability to differentiate a crisis from a mental health emergency? Just kind of think about that. I didn't put a poll in for this one because it's sort of a free text question, but I just kind of want you to think about it. All right, so our next question here, we can go ahead and open up the poll. This is sort of a pre-game question for this next section. Which one of the following is the most common mental health disorder? What do you guys think? Anxiety, depression, PTSD, or schizophrenia? All right, you did pretty well. Pretty well. Pretty close voting there between anxiety and depression. And the answer really is, depends on which data you look at. They're both pretty close, neck and neck. It also depends on what disorders you list under the umbrella of anxiety disorders. And we're going to talk about how that dimension, if you will, has changed a little bit. So we use a manual called the DSM-5. It really gives us a classification of the various disorders, and it helps us improve the accuracy of our diagnoses, which then lead to appropriate treatment. It also helps us in researching. So when we talk about evidence-based medicine and how things change, they constantly collect data and review this information to see, are we using the best methods of treatment and are people getting better because of what we're offering them? So there's the classification, so the title, if you will, of the disorder, the diagnostic criteria, and it's usually kind of check boxes. You have to have this many parts of the diagnostic criteria to qualify to have that particular diagnosis. And then there's a descriptive text that goes with it that gives us more information about the various disorders. So here's a slide from the National Alliance on Mental Health. NAMI is a great resource, so I included it in here. You can see at the bottom, NAMI has a helpline, and it's a 1-800 number. They're even available on the internet and on social media. So if you're thinking about where can I find resources, this is one resource that is available, NAMI. And it just really shows those numbers that we were talking about. But when you look at the left side of the slide there, and we look at 8% of folks have depression, 4% of people have more than one disorder, like I say, when you classify the things that fall under the umbrella of anxiety disorder, 19% of people with anxiety disorder. So we're going to talk briefly about sort of the types of depression. So in order to really qualify as having depression, you have to have symptoms for at least 2 weeks. And there are some subcategories: dysthymia, postpartum depression, psychotic depression, and even I live in the Finger Lakes region of New York, so seasonal affective disorder, or SAD, is pretty prominent where I live. So the symptoms affect how you think, how you feel, how you handle your daily activities, those activities of daily living. Am I able to get enough sleep? Am I able to cook myself meals? Am I able to get to work and be effective with the things that I need to do? And there's just a list of some of the symptoms of depressive disorders, and there's commonality between all of them. Sad, low, irritable, general loss of pleasure in activities, fatigue can be a big one. Or there are some folks that have a more kind of stimulated type of depression, so they're restless and they can't sit still very well. The mental piece is hard: trouble concentrating, trouble focusing, appetite or weight changes, and then when things are really bad, thoughts of death or suicide or even suicidal attempts. And then the last one are sort of the somatic symptoms that goes along with it. And we see a lot of these folks in primary care. I'm fatigued, or I have headaches, or GI symptoms are not really all that uncommon. And it's sort of a diagnosis of exclusion. If I go through and I work you up for all the neurological things that can cause headache, or all the GI things that can cause abdominal pain, and I don't find any real physical cause, then I have to entertain the idea of whether there may be some depression or even some anxiety going on. Again, diagnosis of exclusion, long term. Anxiety disorders, it's more than just worrying about things. The anxiety doesn't go away, and it, again, interferes with your daily activities. And there are some subcategories with anxiety disorder as well. General anxiety disorder, panic disorder, phobia all fall under the umbrella of anxiety disorder. Phobia is the easiest one to manage because it's typically one thing. So you can stay away from whatever that one thing is. There are a lot of commonalities here with the symptoms of depression: fatigue, restless, irritability, trouble concentrating, difficulty controlling feelings of worry, can't stay asleep. And then panic disorder can mimic an MI: palpitations, sweating, trembling, shaking, shortness of breath, those sorts of things. Again, diagnosis of exclusion in our land in EMS. We cannot say, oh, that must be a panic disorder, panic attack. We need to evaluate these folks to rule out those other more life-threatening causes. However, it's not inappropriate to say, have you ever experienced anything like this before? What was it diagnosed last time? And by asking that question, oftentimes patients will say, oh, I had a panic attack before. This feels exactly the same. So at least entertaining the idea on the differential diagnosis and asking the appropriate questions of our patients is super beneficial. Can I feel like impending doom or feel like things are out of control? That's what patients will say. And then that phobia, like I say, it's one thing. You have an excessive worry about encountering one specific object or one specific situation. It's spiders, it's snakes, it's tall buildings, it's elevators. The list goes on and on. In fact, if you want to have some entertainment sometime, look at the actual long names for a lot of these phobias. Some of them are things that even after 30 years of saying Latin medical words, I can't even pronounce them all appropriately. But the idea is you can typically avoid them and avoid the anxiety that goes along with them. However, sometimes you're in a situation where you can't avoid it, and then you end up with pretty significant anxiety symptoms as a result. And the last sort of bucket of common mental health disorders here are trauma-related disorders. And this is the place where we've seen the biggest amount of change in the DSM-5. People who have experienced or witnessed a traumatic event. It could be a natural disaster, it could be an accident, it could be a terrorist act, it could be something that occurred in war or combat, or even something as terrible as a rape incident. And for a long time, when we've looked at trauma-related disorders, we've looked at the disorder itself and sort of escalated. Oh, that's a terrible thing. That person was raped. Or, oh, that's an awful thing. That happened at, while they were in the military, etc. So we can't really look at how bad was the incident. We really have to look at it from the perception of the person. How bad did that person feel, or how did that affect that individual? So there's subcategories of that, and I think I'm going to guess that all of us have probably experienced this at some time in our lives: acute distress disorder, adjustment disorder, or post-traumatic stress disorder. And the one thing that I really want to emphasize is that acute stress disorder is normal, especially with the things that we experience on a regular basis. So it's not bad, and we shouldn't feel bad if we're experiencing some of those symptoms after a stressful situation. It's when it becomes persistent and it affects what's going on in our lives is when we need to worry. So some signs and symptoms. There's a long, long list. Intrusive thoughts, bad memories, dreams or flashbacks. I can think of a particular situation. That was the biggest thing for me, is the dreams. I'd be fine during the day, but the really, really vivid, intense dreams at nighttime were a really big trigger and a tough situation for me to deal with. We try to avoid memories of that specific event. I wouldn't go down the road and travel on a specific bridge where this specific event happened for better than a year, because I knew that that was a trigger, so I just didn't drive that direction. Alterations in our cognition, our thought process, our mood, alterations in arousal or reactivity. So sometimes people react or act out. They're angry, understandably so. So I just want you to know that it's normal to have those symptoms when we experience some significant trauma. All right, we're gonna talk about some of the less common mental health diagnoses that I think unfortunately get a lot of attention, and maybe they shouldn't, because they really are less common. So bipolar disorder, I put this in here because I feel like there's a lot of misinformation, and it's sort of become a colloquial term. People are like, oh, you're acting bipolar. And I think that distracts from and adds bias to thinking about the people that actually have bipolar disorder. So there are specific criteria and different subcategories. There's bipolar 1, bipolar 2, and cyclothymic disorder. And it really depends on kind of how the patterns happen, how dramatic they are, and how frequently they happen. That kind of triggers that classification. But the key is you can have someone that's been diagnosed with depression for a really long time, and you really can't make the diagnosis of bipolar disorder until they have that manic phase. So sometimes people go along, we've treated them for depression, but in reality, they have bipolar disorder and it's gone unrecognized. And that's no one's fault. It's just the nature of the illness, if you will. So that what we're looking for in these signs or symptoms of mania: decreased need for sleep, decreased appetite. People talk super fast. It's almost like if you ever watched a YouTube video on 2.0 speed, that's almost what these patients sound like. They can think about it. They'll say, I feel like my thoughts are racing, and they're doing a lot of things at one time and not doing any of them really effectively. But the biggest clue for me is this risky behaviors that are related with poor judgment. They're at the casino, spending a ton of money, gambling a lot, or other sorts of reckless behavior. That's sort of grandiose thinking. And on the depressive side of things, It's the same as regular depression that we talked about early, but you got to have both pieces to have that bipolar diagnosis. So far less common, but it's used inappropriately in terminology. So I would challenge you to try to get that term out of your regular speech and really be mindful of thinking about it when you're using that terminology. Schizophrenia, another one. Oh, you're acting schizo. Again, I would challenge you not to use that terminology unless we're using it appropriately. Interestingly, that a real less than 1% of the population, it's like 0.7% of the population actually is diagnosed with schizophrenia. And interestingly enough, of that less than 1%, a third of those people will experience one episode of schizophrenia in their entire lives. They're treated appropriately and they never have another problem. They are able to maintain their daily activities and do their regular things, and you would never know. Another third go through cycles. They'll have an episode and then they'll be treated and they'll have a long period of time where they do fine. They function normally, they live in society, and they do great. And then the final third are the ones with the really dramatic, persistent symptoms that are truly disabling. So we hear about people and kind of, I think, unfairly say, oh, that person must be schizophrenic. The likelihood of them truly being schizophrenic is pretty low based on the numbers. Schizophrenia is really typically diagnosed in the late teen years, all the way up to the early 30s. People think that it affects men more than women, but in reality, the diagnosis is equal. The numbers are equal. It just happens earlier in men than it does in women. And it affects how the person thinks, feels, or behaves. They can have a lot of these kind of psychotic symptoms. So altered perceptions, abnormal behaviors, abnormal kind of odd behaviors, hallucinations and delusions. So hallucinations, they hear voices or they see things that aren't there. So auditory or visual hallucinations. And then delusions, those are really tightly held beliefs that aren't supported by any objective facts. An example is given there, like people think that there's someone out to get them, or there's strange messages being broadcast to them on the TV or the radio or through their cell phone. And their thoughts are so disorganized and racing that it is very difficult for these people to even begin to think about taking care of their activities of daily living. You think about your brain going 150 million miles an hour all the time, you wouldn't be able to get anything done. So let's talk about some attitudes here that we need to be thinking about. People first language. This started in 1992, and it's an alternative to labeling people. So instead of saying that diabetic patient, we should be saying that woman with diabetes or Mrs. Smith who has diabetes. So the goal is to really separate the individual from their diagnosis. So it's another challenge that I have for you to try to use person first language and look at things with a trauma-informed approach. I think we'd be hard pressed to find someone who hadn't experienced some traumatic experience, whether it's in early childhood, whether it's later on in life. But I like you to think about experiences of trauma. And in fact, I'm a little late with this poll, but it fits here too. Let's put the poll up. I have experienced a traumatic experience which led to acute stress disorder. True or false? And let's see how many folks in the audience truly have experienced. Yeah, I expected it would be better than 50%. So I just really want you to think about how that trauma can affect the individuals that we see and how it affects us over the long term. We want to make sure our patients feel safe. We want to look trustworthy. We want to offer collaboration, mutuality, so giving them some choices in how things happen. Peer support is important. Empowering them to take some active participation in their care and being respectful of cultural, historical, and gender issues that they may encounter. So how do we do that? Having empathy and sympathy. Empathy is the ability to put yourself in another person's shoes. Oftentimes it's easy to be empathetic if you have experienced the same type of situation. Sympathy is feeling bad even if you can't understand what that individual is going through. So those are two really essential characteristics. Compassion is also important. We need to recognize when people are in distress and come up with an active plan on how to alleviate that distress. One of the ways to do that is to respect people's boundaries. Offer people the option to really stay within their own bubble and set their own personal boundaries. And the same thing is true with us as providers. Sometimes patients are more aggressive or reach out more, and it's okay to define our own personal boundaries. Use active listening techniques. So listen to what the person says, repeat it back to them, or paraphrase it, or rephrase it and change the sentence structure and reflect back on it. Use therapeutic communication skills. So really try to develop a genuine relationship with your patient. Those open-ended questions that we always talk about, think about your nonverbal communication. It's a little harder now with masks on. I realize now how much of the face is really important for nonverbal communication, but they say the eyes are the window to what's going on in people's souls. So think about how you're presenting yourself. Think about your body language, your stance, your gestures, and how you are presenting yourself to the people that you're interacting with. Motivational interviewing, another opportunity. Use reflective listening. Really listen to what the person is saying. And my favorite one is the second one. Reflect on what the person's goals are. I'll say, what are you hoping I can do for you today? Or what are you hoping is going to come out of this interaction? It's a great way to just clarify expectations and make sure everybody's on the same page. We can use that during patient assessment. So first thing we have to remember is that medical crises can lead to these behavioral health situations. So just be cautious of that and include those on your differential diagnosis. Think about those nonverbal cues. Look at the patient's nonverbal cues as well. Always think about safety. Be aware of the setting. Know where your exits are. Use all of your senses. It's not just your sight. I rely on my hearing and my sense of smell quite frequently. And think about appointing a safety officer. If I have an extra person on the truck or a fire's with me, I'll ask someone to really be kind of the doorman and be the safety person. Your job is to look and make sure that the scene not just is safe when we arrive, but that it stays safe while we're interacting with our patients. There's a lot of debate going on about medication options for pharmacologic management. So I thought I would just kind of touch on some of these because it's sort of a moving target. Traditionally, we've used benzodiazepines, but some areas really are moving towards the kind of first generation antipsychotics. I hear lots of talk about Haldol. Remember that does have some pretty significant potential for QT prolongation. So really need to have a pretty decent medical history before we think about using those. There's also some pretty significant extrapyramidal side effects that you can get with those first generation antipsychotics. Oftentimes they'll like Risperdal or olanzapine as opposed to Haldol, because there's less extrapyramidal side effects and less sedation with those. And ketamine, boy, is a big debate across the country with where it falls with appropriate use. There's some areas in the country that are even passing legislation that says it's not allowed to be used by EMS. That could be a whole lecture in and of itself, but just know that it is out there, and some people do have that tool in their toolbox. However, the take-home message about ketamine is it can exacerbate schizophrenia. So if you know that someone carries that diagnosis, this might not be the most appropriate way to go. And then we're going to end by really just talking about the members of the behavioral health team, because we do need an interprofessional approach here. So the psychiatrists, typically they are medical doctors. They've completed a specific residency in psychiatry, and their focus is usually medication. They work with the psychologists, who also are doctorally trained, either in psychology or counseling or even some in education. And they're really looking at evaluations and specific types of testing. Some of them have additional training in different types of therapy. The mental health therapist, typically master's level professionals, and they use very specific therapeutic techniques based on the way that they've been trained. Clinical social workers also are an important member of the team. They typically focus on case management and advocacy, and they are also master's trained. Some clinical social workers also have additional training in therapy services. Don't forget the primary care provider. There is a shortage of psychiatric providers in the country, so oftentimes medication management and some basic therapy falls to the primary care provider. It's the physician, either MD or DO, or we'll get to it later, there's some other folks that can kind of serve as the primary care provider. Don't forget that the pharmacist is really crucial. Many of these folks are on multiple medications, and the pharmacist can really help us figure out what works. Peer specialists, pastoral counselors, nurse practitioners, physician assistants, there's so many members of the team. And the real key is good interprofessional collaboration and communication. Types of therapy, I just kind of put this in at the end. You may have heard some of these: cognitive behavioral therapy, psychotherapy, eye movement desensitization and reprocessing therapy, or EMDR. So much like we look at what's the right type of blood pressure medicine for an individual patient, there's different types of therapy that are appropriate for different situations. So, and think about telemedicine has really opened the door to accessing therapy services, because traditionally they've been done in either an inpatient or outpatient setting, or some sort of partial hospitalization where people go for parts of the day. But now you can do therapy from your own home, which is pretty cool. There are some resources called peer support workers, and this kind of came out of recovery and substance use, but now we're seeing more peer support services in behavioral and mental health. So if you have the opportunity to take peer support training, I would encourage you 100%. I always like to include self-help resources, and there are definitely some attachments, some handouts attached to the webinar that also include some references and some phone numbers that you can utilize for getting help. Well, let's throw up that last poll here, just to kind of try to normalize things a little bit. I have sought help from a mental health professional in the past, or I'm currently seeing a mental health professional. True or false? And I will be the first person to say, I have in the past multiple times. I am not currently, but I have in the past. Mental health is nothing, or mental illness is nothing to be ashamed of, but stigma and bias shame us all. Good, I'm glad to see those numbers. That's awesome. Well, thank you for spending time with me today. I appreciate it. There's some contact information for me. If you're ever interested or have further questions, by all means, send me an email, send me a note, find me, contact me. I'm happy to be a resource for folks along the way.
Thank you so much, Melody. We appreciate your expertise, and we also appreciate the opportunity you had to share with us those options for providers to be peer resources. That's really cool, to be able to support the community and learn how to do that. We will be launching a mental health website in a couple weeks that will have some of these additional resources located there as well on careercert.com. So we will send you more information about that. And we just want to remind you that if you are looking for the CE credit today, you will receive an email within 24 hours. And that credit you get by 1, attending, and then 2, completing the assessment that you get in the email. And then information around redeeming your certificate will also be in that email. So if you have any questions, you haven't received anything within 24 hours, feel free to email marketing@careercert.com and we'll make sure you get that. Thank you so much for attending today.